one of the greatest things for me about going to medical conferences throughout the year is being introduced to new concepts, innovative new approaches, and people who are just doing incredible work. And that's why I had to have on the Delivering Health podcast Matt Halpert. He's a brilliant PhD who is doing work commercializing and bringing into clinical practices dendritic cell therapy. And if you haven't heard of that before, you're in good company because it's not widely known in the general public, but it holds promise to be an innovative game changer for cancer treatment. It's been around for a while. There have been early medical failures, but those technology and looking at how dendritic cells operate and how to get them to do what the clinicians want them to do in terms of being effective at killing cancer cells, effective at being the immune system's surveillance cells against cancer. Well, a lot of that now looks like those challenges have been overcome. And so, without further ado, Matt, I want you to educate me and the rest of the audience about what you're doing, about this approach, because it's mind blowing.
Well, thank you. And thank you for having me on and giving me this chance to talk about this work. Um, what you say is true. A lot of people don't really know about dendritic cells. So I come at this, so I am an immunologist. That is what my doctorate is in. And I spent a good decade in the lab doing hands-on research with the immune system. Um, we know the immune system is, uh, you know, phenomenally capable. It's very complex. It's got this beautiful, different set of cells, all capable of doing jobs, including getting rid of cancer. Um, and we focus on the dendritic cells because they run the immune system. That's their job. They're the general of the immune system army. Their job is to see the threat and organize the response. And if a patient has cancer, there is a failure at this level to some degree. It could be the whole thing, it could be just part of it, but to some degree, the dendritic cells seem to be ignorant to the threat. And so, for that reason, it's not surprising that a lot of people over the years have tried to use dendritic cells in the clinic, and it makes sense. Biology says it makes sense. Use dendritic cells to reprogram and rearm the immune system to fight cancer, and hasn't really worked. And it's just unfortunately led to a lot of frustration and disappointment, and the unfortunate belief that because it hasn't worked, it will not work. And so a lot of people have moved on and have stopped looking at dendritic cells. And, I know we're going to get into the weeds a bit here, but kind of a long story short is if you're trying to get your car to go from the West Coast to the East Coast, and you're trying all these different things, you're trying to play with the radio and you're trying to turn the windshield wiper on and you're playing with, you're moving the cup holder and the seat around and it doesn't work. Is it really the car's fault? Or is it because you just forgot to turn the car on? And so, the discovery we made that is inherent and is based, the foundation of everything we do is no one has actually ever turned dendritic cells on in the correct physiological way before.
And I think
That's
you
the missing
you referred
piece.
to this when I met you and had the conversation. You referred to this, I believe, as priming the dendritic cells. Is that correct?
It's yes, but there's a lot of different ways to prime the cells, or at least that's what people have tried to do. It turns out the dendritic cell essentially has two-factor authentication. I mean, it's not really that surprising. When you're choosing to eliminate cells in your body, that's a huge decision. You do want that tightly controlled. You don't want your immune system to suddenly just start attacking all these different cells. And so the dendritic cell, when it sees a threat, it can't just see it in this single linear, straightforward fashion like everyone's been trying to do. It actually has to see it in two different pathways simultaneously for it to realize it's the real threat and to unleash or release the brakes. You unlock the failsafe, and that's what gets the dendritic cell to go. So we're not just taking cancer and throwing it at the dendritic cell and priming it, but we're effectively double loading it. We are turning two keys simultaneously with the target information itself. And that is what is releasing the brakes on the dendritic cell to reprogram and relaunch the immune system to target that.
Yeah, we're going to get into those details here in a little bit. But before I do, I want to sort of back up a little bit, get a little bit more of a big picture here. We have dendritic cells. So I'd like you to tell people, where in the body are they produced?
Mm-hmm.
And if we have them anyway, why aren't they working? And they're our primary cells that control killing cancer cells. We're always producing cancer cells in our bodies. It's just part of our normal
Yep.
physiology. But in a healthy immune system, we can keep that in check. So, what goes wrong with that?
Yep. So yeah, obviously we have dendritic cells. Now, normally dendritic cells are tissue resident and in the lymphatic system. In other words, if you do a blood draw, you're not going to find a lot of dendritic cells. Usually less than 1% of those cells are actually going to be dendritic cells. Dendritic cells, the precursors will of course start in bone marrow and circulate in blood, move into your tissue, and turn into these beautiful dendritic cells where they sit. They are the sentinels.
Yeah, and
They
in
are
fact,
holding guard.
when we do a white blood cell count, which everybody listening to this has had done in a blood draw, if they look at that or talk to their clinician, dendritic cells are not part of that report.
No, not at all. The dendritic cells will end up being differentiated from monocytes, which is in the report.
Yep.
But right, dendritic cells are not in that report. I'm not going to rag too much on just our standard, the way we do standard testing. I mean, lymphocytes is, well, is it, it's T cells and it's B cells. And when it's T cells, are they CD8 killer cells? Are they helper T cells? Are they exhausted T cells? Are they regulatory T cells? You don't get that breakdown in, just
Yeah,
a
I guess my point in saying that is if dendritic cells are the key to keeping cancer cells in check, and they showed up on a white blood cell count, and I guess this is more of a question for you. If they happen to appear on a white blood cell count, and we saw the dendritic cell numbers going down, could that be an early warning sign of increased cancer risk?
That would be something that I don't think's really been studied. So again, dendritic cells are not normally in circulation.
No, I know, but let's
And
say they
so,
were. If you're able to test them over time, I mean, I don't know if even if they're in resident. This is a hypothetical question. If we were
you'd
able to
have to,
test them and monitor them and saw their numbers, is it their numbers are going down, or they're just not able to be active against the cancer cells?
yeah, I don't think it's a numbers game. This is actually, yeah, cancer doesn't usually, there are always cases, but cancer's not usually just going to win because there's more of it. If you think about it, it starts as one cell, right? And that one cell replicates and it becomes two and it should stop. But two becomes four, four becomes eight, eight becomes 16, and so on. What and it's just allowed to keep going. And if you take those, if you could take somehow that patient's dendritic cells and this cancer and you put it in a petri dish, the chances that the dendritic cell activates probably is pretty slim. It's not that it's incapable or that it's a numbers thing. It's that there's something fundamentally hiding the cancer from this cell. The dendritic cell is not correctly processing it. Now, the truth is, and I know you're shooting for about a 30-minute podcast here. We would really have to start getting into a lot of speculation about what actually has gone wrong there. The same way we would have to if we wanted to talk about all the underlying mutations that led to the cancer in the first place. What caused it? The foods you eat, the sun exposure, what are you putting on your body? Are you getting enough sleep? I mean, is it just something you inherited? Was this a mutation you were born with? GI dysregulation. Like we could really start getting into all these different, and the truth is, as of today, we don't necessarily have all those answers other than it happened, the cancer's here. And in that same way, the dendritic cells have failed to launch correctly. They have failed to see it and recognize that this is a problem we need to eliminate. And so you ask a good question. If we could longitudinally, somehow sample cancer or people for their dendritic cell populations, it might not be a numbers thing, but could we see fundamental changes in their phenotypes And as a certain change happens, that leads to a higher risk of cancer. It's a great question. We're going to have to get a lot of people to sign up for these studies. That would be a really good thing to see. It's not something, to my knowledge, that anyone is really hardcore looking at.
But what you are hardcore looking at is how to take existing dendritic cells and help them be effective at killing cancer cells.
Yeah, and that's the thing. And, it all starts in the lab. I think I told you before, when we talked before, none of this started as a cancer project. It was a group of immunologists trying to figure out why are the dendritic cells not working? What are we missing because they should be working? So in a number of different systems that has now evolved to a number of different cancer patients, we repeatedly, almost always are able to take a patient's dendritic cells, a patient's cancer, and when we take that cancer and then properly double load it into the dendritic cell, into and onto the dendritic cell to activate these simultaneous pathways, we get beautiful, crisp activation, as if it just as it should have always happened. It's not that it couldn't do it. We're watching it do it. We can now take these dendritic cells, we put them back into the patient or the subject, depending on what we're studying, and we see if we don't just see an immune response, we don't just see more of an immune response, we see a unique immune response, something that is truly geared towards what we call a Th1 immune response, focused on targeting and eliminating these cells, all expressing the signatures that were part of the target that was subsequently double loaded into the dendritic cells. Happens over and over and over again. So I certainly couldn't faithfully tell you that someone with cancer that their dendritic cells can't do it. See it all the time. We've treated a number of patients with low TMBs, low tumor mutational burdens, and sometimes they're concerned. I don't have a ton of mutations. That's all the more reason you should do this. If you have tons and tons and tons of mutations, you're actually more likely to get lucky and have a sporadic or a spontaneous immune response, engage. You've got 50 mutations. It's possible that something might trigger the immune response to kick on. If you've got 4, it is less likely. And some of these patients are under the impression, maybe from their doctor, that, oh, you don't have a lot of mutations, immunotherapy won't work for you. No, what they mean is that blind, blunt immunotherapy, or really immune stimulating tools, probably will not engender the education your body needs. And that's true. But when you do something like this, 4 mutations, 40 mutations, we've seen it repeatedly. Again, you take it, you properly double load the dendritic cells, off it goes. You can almost see them wake up. Oh, are we supposed to be fighting the things with these 4 mutations? Okay, well, let's go to work. And then it does. And I'm not saying that means the cancer runs away and hides. I'm not saying that it means the fight's over, but the fight actually finally gets to begin. And I just don't know of a better weapon you can use than your dedicated, specific, powerful defense system, the immune system. And I'm an immunologist, so you take it with a grain of salt, but I know of no other system that's in place and as capable as it. And so that's why we are so passionate about trying to get this forward. We're not saying it's magic, but every cancer patient should be getting their immune systems fixed to get in the fight and start doing its job, because otherwise you're kind of carrying around dead weight, and it's actually much harder.
You mentioned maybe a conventionally trained physician, oncologist, when they think about an immune stimulating therapy, it sounds like it's a very different therapy and approach than what you're talking about. So other people may have heard about those, especially if they or someone they love had cancer or has cancer. So could you just briefly compare and contrast what somebody with the sort of standard of care understanding of immune therapy is compared to what you're talking about?
Sure. And I'm going to be careful. I don't get myself in trouble, and I certainly am not looking to anger a bunch of people. So I'm just going to stick to the facts. People tried. There's a lot of effort to get dendritic cells to work in the clinic, and that didn't really work. And when that didn't work, look, what does everyone have to do? Some people are kind of crazy, like me. I mean, you stick with dendritic cells, and we're going to find it. But a lot of effort moved on to what are other ways we can utilize the immune system to get engaged and to fight. And so the most predominant forms of immunotherapy that evolved out of that are CAR T therapy, which we're not really necessarily going to talk a lot about today, but CAR T and checkpoint inhibitors, which, yes, most cancer patients somewhere have heard of checkpoint inhibitors, seen a commercial for Keytruda. These are absolutely phenomenal, and so really exciting. When the first drug was approved based on clinical trials leading up to 2011, what we saw is that you take a sample of cancer patients who have no real chance of survival. It's not good. They do this form of immunotherapy, and a small percentage of them lived, like, durably. Just maybe it was only 5%, 10%. Maybe it wasn't a huge number, but all they needed was this to live. So why is that impressive? Well, what is a checkpoint inhibitor? When immune cells that are educated and activated are fighting, look, the truth is it doesn't take that long to fight off the flu normally in a healthy, otherwise healthy person. So a 6-month fight is not what the system is designed to do. So over time, as it keeps fighting and fighting and fighting, the immune cells can become worried that they're autoimmune. They're worried they're doing the wrong thing. Why is this fight taking so long? And they can start to raise off switches, breaks, what we've called checkpoints. Very popular one is PD-1, program death, receptor 1. It puts it up there for, if I'm doing the wrong thing, please turn me off. And a lot of cancers have learned how to hijack that. They express PD-L1, the ligand for it, and they stick it out, they press that button, and they turn it off. Immune system quiets down, and the cancer wins. These drugs get in the way of that. They're inhibitors. They simply shield that interaction from happening, and it allows that immune cell to keep fighting harder and longer. Basically, you're delaying what's called immune exhaustion. For some patients that do have an educated, activated immune response, some cancers are inherently immunogenic, more so. And the immune system is trying to fight. It's just too weak. It's just not going to win against this drastically proliferative mass. You throw these drugs into the mix, you give them a little more time, a little more power, and they can win, or you can at least, delay progression or see some benefit. So these drugs are very beneficial. No problem with that. Yes, you have to watch out for autoimmune sequelae because they're not cancer specific. So this is going to happen in your whole body where your immune cells are going to be a little, maybe too active. But here's the thing, as powerful as they are, and all these big companies, Merck, Bristol Myers, great. But where's the component of education? What in that taught the immune system what to fight? And if you weren't already in the fight, is it likely to help? And the answer is no. And no one's going to tell you otherwise. That there is no education there. It's not designed to do that. Pet peeve of mine is a lot of doctors have, unfortunately, because checkpoint inhibitors are so prevalent and just the leader in the clubhouse right now for immunotherapy, they've generalized all immunotherapy to really just checkpoint inhibitors. And this is fair. I'm not telling you there's a ton of dendritic cell, FDA approved dendritic cell vaccines. There aren't. So the patient doesn't know all this science. The doctor looks at their cancer and says, I don't see PD-L1. Immunotherapy will not work for you. The doctor's not going to get into the weeds about how those drugs work, what they're designed to do, and so the patient hears immunotherapy won't work, my immune system won't work. It's just kind of a gross generalization. Checkpoint inhibitors may not be a good move right now. That's true. You have a low mutational burden, no PD-L1, they're sure, probably a waste of time. That doesn't mean that something like this, which is fundamentally drastically different. This isn't a drug. This is your dendritic cells, your cancer being properly reintroduced. And upon that reintroduction, the dendritic cells say, I should have been fighting all along, and I now need to kill you. We put that back in the body near important draining lymph nodes, and now the patient's immune response kicks on. That's very different. That includes the education. That includes power. That includes a lot of things that you're not going to get with an off-the-shelf drug. This is called personalized medicine. Yes, it's more expensive. It's harder to do. It's tougher to scale. All that's true. But do you want something that's going to give you that personalized education or not? This is what it takes, at least in 2026. And so if any of the viewers are following along with me here and you're wondering, well, once I have that immune education, would it be synergistic to consider adding checkpoint inhibitors? Probably, yes. Number of our patients, they come to us, their cancer is PD-L1 negative. 6 months later, they do a biopsy. Guess what? PD-L1 positive. Why? Well, it makes perfect sense. The cancer wasn't wasting energy before on a defense it didn't need. Now there's an immune response attacking it, and now it's trying to fight it off. And again, we're not saying it's not going to try to fight, but the cancer itself is almost telling you, all right, the immune system is now engaged, it's fighting me. And that would be when maybe adding, these, checkpoint inhibitors, or if you want to go a different route, there are other interesting routes coming about that may be effective in reducing those checkpoints. And there's the opportunity for big synergy. Anyway, I know I said a lot of words to your question, but it's a very different technology.
Yeah, no, I loved your answer, and it's got me. I've got a lot of questions based on that. I don't think we'll be able to get to all of them, but I want to be clear that make sure people understand, and I want to make sure I understand. I mean, correct me if I'm wrong. What I'm understanding is that it's not the dendritic cells themselves that are attacking the cancer. The dendritic cells are differentiating into cancer fighting cells.
Well, if you'll let me modify that statement a bit.
Of course, please
Yeah.
correct me.
Yes, the dendritic cells, like the generals in the army, very often, they're not going up to the cancer and fighting it. What they're going to do, so something else we do that is unique, and I'm kind of sorry that this is unique. It should not be unique. It should be very standard. But I just told you dendritic cells aren't in the blood. There are other dendritic cell efforts where after they try to load the dendritic cells their way, and I'm not going to blast them, just whatever, but then they infuse them in the blood. It's like an IV drip. Why? I mean, dendritic cells don't migrate well from circulation. They get stuck. They don't have the right programming to do that because they're not supposed to be there. So that's not what we do. After we double load the dendritic cells and we get them functional, we actually will then do image-guided injections. This will be done by an interventional radiologist near draining lymph nodes. And there's reason for that. And what do I mean by that? If you have brain cancer, we're going to target lymph nodes here, not in your foot. If you have foot cancer, we're not going to target here. There's a reason to target where the nodes may already be experiencing that antigen prevalently. The dendritic cells are going to go into those lymph nodes, and they're going to talk to your foot soldiers. All the guys walking around carrying the guns that are going to do the killing, that think there's no fight to be had, are now being instructed. They're being given all the signals. This is what you're looking for, and this is what you need to do when you get there. When those cells see that, when that connection is made, so we're talking about natural killer cells, killer T cells, helper T cells, when they start getting primed, they're going to start proliferating, which causes lymph node swelling. And then they are going to go out, survey the body, look for the enemy, the target, and they are going to start fighting. And the dendritic cells remain in the lymphatic system where they are priming and priming until they run their course. So now you want to, again, are there things you could do to give those foot soldiers bazookas? Yes. I mean, again, there are some other things you can do to improve the fight and improve the battlefield for sure. But end of the day, throwing bazookas onto a battlefield where no one even knows there's a fight is a little cart before the horse. Get your soldiers educated, armed, and engaged, and then you can look for these other things to add. So that's how the dendritic cells communicate to the immune system within the lymph nodes to become engaged and go fight.
Phenomenal. And what types of cancers has this in humans been tested in so far, or treatments been done?
So double loaded dendritic cells is now for FDA clinical trials. It's in 2 of them, 2 different indications with a third coming. Because we so strongly believe that double loading dendritic cells is going to properly activate them from step 1, we did not pick easy cancers to test this against. We did not say, well, let's just pick something easy and see if we can move the bar a little bit. No, we picked glioblastoma, which is a very aggressive brain cancer. And more to the point, almost every patient in the phase 1 trial had the unmethylated MGMT promoter IDH wild type phenotype. What this means is the tougher kind. The tougher kind of glioblastoma, in which standard of care treatment is debatable whether or not it actually improves anything at all. The other, and that phase 1 trial has finished. It went very well. We saw absolute phenomenal results and statistically significant results in increased median survival and long-term outcomes. A couple patients now are past, they're getting out there to around 3 years, which is just not normal for glioblastoma. And so we're excited by that. And a lot of people are excited, which is why the bigger clinical trial of it, which is now open, is going to be at maybe 20 different institutions across the states, some very big names. I don't know that I can mention them all here, but it's not going to be hard to find to be able to get this treatment if you have glioblastoma. Pancreatic ductal adenocarcinoma, a form of pancreatic cancer, is currently open. We have patients in that trial now past 5 years. And that is going. And refractory melanoma is going to be coming out somewhere here, we hope within the next couple of months. And that's not melanoma patients. It's melanoma patients that have stopped responding to treatment. We think we can restore responsiveness. And so we're gonna run the trial there. We've been fast-tracked by the FDA a couple of times, meaning they would like to help us move quicker. We've won a couple of awards. We've won some grants. There's a lot of people in the know that are excited by this science. I'm going to say even in the glioblastoma, we've treated a couple relapsed GBM patients, which at that point, average survival is expected to be 5-6 months. We're talking, there's really nothing you do there. And I'm just going to tell you, as of right now, we have patients at month 15 and 18 from that group, which is just, we need more. We need more patients, but that's pretty unheard of. Now, that's in the trials. That's the standard route. If you're asking about an immunosine, we've actually now treated over 30 different types of cancer with double-loaded dendritic cells. Basically needs to be a solid tumor we can sample. I mean, we need a sample. It's your cancer. We need to be able to get that. So if you've got a solid tumor and you fit within the inclusion criteria, and we have inclusion criteria. It's not a walk-in clinic, but we have not noticed that this is specific for one type of cancer or the other. I personally don't know that there's a huge difference in cancer that started in the kidney versus the colon versus the lung. I mean, it's a threat to your body, and your immune system should at least be able to fight it. They all have different rates of progression. Again, I don't want to accidentally mislead. It's not easy, and it's not like there's just some guarantee of cure here. But there's not areas that are off limits. They should be monitored by the immune system.
And I imagine in Immunocene, your company, which we haven't really talked about yet, but we will. You're gathering data. You're not just, you're keeping records. 30 different cancers you've treated. How would you characterize the results? I mean, typically, as my understanding is, when you're looking at cancer survivor, a 5-year survival rate, surviving for 5 years is considered surviving cancer. And so, correct me if I'm wrong. I don't know how how you would slice that data, but
Yeah,
for different cancer types, what sort of results are you seeing within your clinic?
sure. And you brought up a good, I'm a scientist. The company's run by scientists and doctors, so we're all a bunch of nerds and data junkies. And so, for example, a lot of patients have come to really appreciate that we run, we do something called flow cytometry on every patient. And so we talked earlier about CBCs and, blood work, looking at your white blood cell count. And I said how that's not really deep enough. We do go deeper. So when you come to us, we actually look at your immune system at the level that an immunologist would look at, study, publish before we start treatment and throughout. And we're looking for things that show us signs of immune education, reprogramming, power, memory. We're looking for those things in a far more specific way that is not done at all in any standard or commercial way. I don't want, I will tell you now, patients should not call you and say, I want to get that done. Where do I go? I don't know. There's not a lot of spots in the United States, if any, outside of academic institutions that do that degree of study. But I think it's important. We're looking to see, did your immune system actually reprogram and start fighting? Because that's what we're trying to do. Again, we didn't say we're not surgically cutting out the cancer. We're getting your immune system educated and fixed. So we collect a ton of data. Here's the thing. About 90% of the patients coming to us at Immunization are stage 4, post some sort of failed therapy. I'm not telling you that the best time to do this is in the 4th quarter of a game with 2 minutes left. Probably not. It probably would be a little better if we could get sooner, but because of where we're positioned, that is a lot of what we get. And so when you talk about the 5-year survival, we're not getting people at the start of their diagnosis. We're getting a lot of people at year 4 of trying to make it to a 5-year diagnosis. So for example, we got a stage 4 ovarian cancer patient who probably got to us right around those 3.5 years after her diagnosis. Didn't have a lot of time. We treated her. I actually just talked to her the other day. She's now 7.5 years past that diagnosis. So it's been 3 years, 3.5 years since we treated her. And she's here. She's living her life. She's got jobs. She's visiting with her son right now. Like, certainly this isn't like destroying her quality of life. Like, she did the treatment and she's still going. I'm saying this first. We have a ton of examples of patients getting to NED. She's not NED. All the metastases are gone, but there's like this one remaining lesion in her pelvic region.
Could you just
So
define that acronym NED? I don't think people know what that is.
no evidence of disease.
Thank you.
Yep. No, I don't like to say, it's just I went to grad school. They knock hyperbole out of you. So cure is a little strong, but she brought up a really good point. And I bring this up because I just talked to her. She said, well, when I came to you, I was stage 4. I was probably out of time. I'd say now I'm maybe stage 2, and it's just been pretty stable there. And I said, people don't think about like restaging backwards. Like, once you're stage 4, you're stage 4. They don't really ever go back and say, hey, good news, you're only stage 1 now. So if we reversed her staging, and she's now 7 years past diagnosis of something that had really no shot at making it 5, that's obviously benefit. Just by virtue, you could guess what our 3 most popular cancers are just by what they are, right? Prostate, breast, and colorectal. I don't know if those are going to be our best. I think maybe, we've seen really strong results with melanoma, urothelial, bladder, renal, kind of anything in that area has been really strong for us. Brain has been pretty strong. Head and neck has been polarized. I'd say we've had a couple patients where I'd tell you just really didn't work, and then a couple where, wow, could not have gone better. Can't tell you exactly why, but we've seen that. Prostate, we have a number of, I'd say, well, I want to be careful with stats that I give because I know people hang on that, but we have had a number of prostate cancer patients that have come to us trying to avoid, doing massive surgery or something more major. And it's been very successful for a lot of them. Not all, but a lot of them have been able to do this treatment, and it kind of puts the cat back in the box, and has either stabilized there or the cancer does go away. So personally, for Immunization, we haven't actually been around 5 years yet. It's going to be tough to give you super long numbers. I will tell you that we have I looked this the other day, about 78%. So we have about a 78% objective response rate.
That's amazing.
So it is a little unbelievable. And we're going for more than just objective response. We take it personally. We really want to get better than that, but I don't want to be naive. Cancer is very hard, and that's a very high objective response rate. It's not every patient, but most patients will see that. Um, um, about 80% of patients have made it a year. About 40, so let's see. It depends how you want to really break down stats, but um, because again, we are still kind of young, and so we're still like collecting this data. But absolutely, we have patients that have made it 3+ years, which is about how long we've been around.
Amazing. Now, with this approach, do you see it as either or as an adjunct? Meaning, if somebody was interested in this, would doing chemo and radiation not be advisable at the same time? Do you even know the answers to those questions yet? I mean, I don't know what your position is on
Yeah,
what science says.
the way we view it, so patients can't get to us without us conducting a medical review. We need to see your latest scans, your latest labs, your latest oncology notes, and we're going to review your case. If you have NGS reporting or anything else, you send that. We don't charge for this. This is work we do for you for free. What are we doing? We're looking to see, is it safe to proceed with this treatment? Is it ethical to proceed with this treatment? And what do I mean by that? I mean, if you have 2 days to live, no, this is not going to be the move for you. So safe, ethical, and then what is the best path? We we get it. Patients come to us and they don't want to hear us say, we really think you need to do a couple rounds of the chemotherapy your doctor's prescribing. They don't want to hear that. But sometimes that is the best move. So whatever our medical team, which does include oncologists, interventional radiologists, these licensed board certified doctors, our goal is you, the patient, winning and hopefully living another 50 years and looking back on this as a distant memory. That's our goal.
Love
Do
it.
I think you should get your immune system fixed and fighting and then have this immunological memory? Yeah. There's no way I can understand the science as I do and say anything otherwise. Does that mean this is the only thing you should do? Depends on the case.
Yeah.
You know,
Makes
if
sense. Yeah, that
if
makes
you've
sense.
got a long horizon, tons of time, it's one of these things where you're really not in a hurry to have to do something. Yeah, give this a shot. Because if it cleans it up and you don't have to do all that other harsher, poisonous cutting, great.
Yeah.
But sometimes patients need that time. You need time for your immune system to work, and it may not be the right move to ignore all the other things that are a little quicker at poisoning the cancer and slowing it down. Chemotherapy can do that. Radiation can do that. Now, if you're only doing those poisons just for the sake of doing it, trying to get a few more months of life and it's going to be poor quality, I get it. A lot of patients don't want to do that. That's not what this is. We're looking at how do we synergize and combine. And to answer your question that you kind of asked, it depends what it is. Sometimes if it's not a horribly immunosuppressive chemotherapy or it's low dose, we can do this alongside that as an adjunct, and they can synergize together really well. Maybe it's not 10 and 10, maybe it's 5 and 5, but 5 plus 5 might equal 500. I mean, you might get a very quick response. We've seen that plenty. A number of our patients will do this and then go home and do low dose chemo, and the results are, kind of insane.
Back to the
Um,
what you said before, it's personalized medicine. And
yeah,
we've gone over the half hour, and I could keep talking to you, I think, for
yeah,
another hour. It's really amazing what you're doing. I have two questions
okay.
that sometimes when I ask a question, I think it's a simple question, but it may be a complex answer. But I'm hoping that they're just simple questions
I'll try to do
for the
that.
sake of your time. Um, is this a one and done, or do people need multiple rounds of treatment?
So right now, the way this works, and I'll keep it simple, when you come to us, we're going to take some tumor sample. We're going to take a blood, a blood to make your dendritic cells. We're going to make your personalized vaccine of double-loaded dendritic cells. And our normal plan is then to give you 3 shots of a perinodal injection of your dendritic cells spaced about 2 weeks apart, following just kind of normal immune kinetics of priming, boosting, memory. So 3. Now, we're probably going to have more dendritic cells than that. We, at no extra, there's no storage fee, we're going to cryopreserve them and keep them. And then you continue to collaboratively communicate with us. We're not going anywhere. And if it makes sense at any point, you start seeing immune exhaustion, you do have to do something that's kind of immunosuppressive, like a few rounds of chemo. We're going to talk about when or if it makes sense to come back for a boost and kind of re-up it. And so we're still exploring when is best to do that and if it's best, but it's basically one and done for this period.
Yeah.
Come get this done, your immune system's on, fight strong, have your immunological memory, completely defeat the cancer, and yeah, move on. Like we don't need to keep coming back over and over
You're in
again.
clinical trials now, as you mentioned. It's not an FDA approved treatment, and
Correct.
yet you are talking about treating patients. So,
Mhm.
how can people, if this is not approved in the US, I I know the answer to this because we talked about it, but how can people then access this?
Mhm. Yeah, so we're certainly not trying, and whoever's watching this, our goal is not to skirt the FDA or the US system. We need to do those studies. We need to get those approvals. They're important. This is biology. There are patients that can be helped now that don't have time for these trials to finish. If you have breast cancer and we don't have a breast cancer trial, you can't get this. And at the end of the day, when this is a fundamental fixing of your own immune system, we wanted to try and find a way where we could legally and ethically and with the right scientific rigor bring this to the clinic safely. With that said, our first location is in Cancun, Mexico. We have an approved palliative care protocol, meaning if you don't have easy cancer, then this can be reviewed by a team of certified doctors that we have that can say this is a reasonable effort for you. You have to sign informed consent. You have to know you're gonna talk to us. You're gonna have to know what you're getting into. But so long as those things are in place, and we've approved you, which is not a given, but you're a good candidate, then you can come to Cancun and we will do nuts to bolt there. We do the biopsy there. We do the apheresis to get your blood there. We do the administrations there. We do a lot right there in Cancun over the course of about 6 weeks. And so you can simply go to our site at immunocine.com. That's IMMUNOCINE. So immunocine.com. You can apply. I mean, you apply, one of our patient coordinators will reach out to you pretty quickly to start the process of welcoming you and onboarding you and working to get your records. If you're a physician, there's a going deeper section on our site with more treatment inclusion criteria, more data, and there's a refer a patient section. You can just refer the patient directly. And of course, you can follow us on Instagram and LinkedIn and Facebook and all these things. But honestly, our website, uh, if you apply, we'll reach out pretty quickly.
Amazing. I was going to ask where they can find you. You just said it, so thank you. Immunocine, IMMUNOCINE.com. That'll be in the show notes too. Thank you so much for being here. I mean, what you're doing is revolutionary in the world of cancer and immunotherapy, and I wish you the best of luck. Really bringing this through the FDA process. It sounds so promising, and I'm thrilled to know that this treatment, which makes sense biologically, it makes sense. It's really working with the body's own immune system and fight cancer fighting cells, is non-toxic, is available to people legally, and as you said, ethically, and approached in a very rigorous scientific manner. So thank you. I wish you best of luck, and I hope this is a huge success, not just locally here, but truly globally for everyone, including you and your company.
Thank you for that and for having me on.